Greetings everyone, welcome to another episode of The Professionals You Should Know. This show is about uncovering the journeys of professionals from different industries. And today we have the superb and outstanding Christopher Agu, who is an advanced practitioner sonographer. It's a pleasure. Thank you for joining us.
No problem.
So, what is it that you do?
I'm a medical sonographer.
Okay, so what's that?
So sonography is actually a wide area of specialty in radiology.
Right.
We do a lot of when you hear about sonography, it just encompasses everything about ultrasound scan.
Yes.
So, but because of how diverse the profession of the specialty is, we have different professionals coming and they practice sonography too.
Right.
So we have different aspects of sonography in question.
Okay.
We have those that specializes in obstetric scan. So
Right.
that is for pregnant women.
Yeah.
So we check the pregnancy at different stage of the pregnancy progression.
Yeah.
So we have what we call the early pregnancy scan. We have what we call the anomaly scan. We have the growth scan.
Right.
So when a woman conceive, at the first between the first week of conception to the 12th week of conception, we term it as the first trimester. So then the baby is still forming. There are many complaints that comes. The pregnant woman tends to complain, and in the hospital we have what we call the early pregnancy unit that tends to handle any complaint arising from that first trimester gestation. Okay. So everything that has to do with obstetric scan, we have sonographers that are skilled to check the baby to make sure everything is fine. You can check the baby through either the transvaginal approach or from the tummy. So in the first trimester, the baby is still small. Especially between the let's say when the scan starts seeing features of pregnancy, up to the time, let's say around 8 weeks, it's very difficult to see everything clearly while viewing from the top. You know what sonography is? It has more like a transducer, a camera. Let me use it in a literal term. More like a camera that is inbuilt in a structure we call the probe.
Right. Yeah. Okay.
That's used to through. So when you are viewing from the top, you see little information or limited information at the early stage of the pregnancy. Okay. So they tend to offer more internal scan using another kind of special probe or camera. Then we go through the transvaginal approach and we see better.
Really?
So it's an intimate scan, but you have to follow a lot of protocols, a lot of guidelines, So those guidelines help. We can have a chaperone in the room. Because it's an intimate investigation. So that's obstetrics. In the second trimester, we check for any abnormality. So you see people born with Down syndromes, you see people with cleft lip, spinal bifida, all those stuffs. That's what we check in the second trimester.
You can actually check that?
Yeah, we check it. So we have all those, any structural abnormality can be viewed
in the second
trimester.
So is that most of the time where there will be a structural problem?
Sonography, because let me just say in the UK is a bit more organized than most other countries. Let me just say some developed countries have more like an organized system. So we have the Public Health England that have policies, or let me call it protocol and guidelines for second trimester scan. That's the anomaly scan now. Now what they do is that they give you let's say 11 pathologies that must be seen if it is present within that range. So we have 20 weeks of pregnancy up to 18 weeks of pregnancy to 20 weeks plus 6 days. We are meant to see 11 condition if it is there, and it now has a detection rate. So for instance, we say acrania means absent of the baby's skull. So we can see that in ultrasound where the baby doesn't have his skull.
Really?
So it has up to 95% detection rate based on the policy.
Wow.
So if as a sonographer, you do a scan between 18 weeks to 20 weeks, and there is no skull and you miss it, if if there is any legal implication, you are going to be cutting it because you are expected to see it because it has high detection rate, 95%.
Right.
Likewise, something like spina bifida, defect from the to anterior abdominal wall, we call it omphalocele and all that. So the last part of the obstetrics is now the growth scan, where we now check, okay, the baby doesn't have anomaly or the baby have anomaly. Now we monitor the growth. That is dependent on the midwife, the clinician handling the case to refer, okay, the mother is not feeling the movement of the baby, or there is reduced movement and all that. They can say, okay, let us have a growth scan at 28 weeks, at 30 weeks, at 36 weeks.
Right.
So that's aspect of obstetrics. And one thing unique about that aspect is a lot of complaints.
Yes, I can imagine.
Yeah, because it has to do with the baby.
Yes,
it has to do with the mother.
Yes,
in contrast to Nigeria and most other countries, I always say it in my previous video in my website. Here, a lot of people are emotional.
Yeah,
highly emotional. So it is. For you to be a successful sonographer, you have to understand the aspect of when they have demographic changes. Know what is peculiar to certain people, peculiar to where you are practicing, how you talk to them, because when in Nigeria, for instance,
is that where you studied in Nigeria first? Or
I first studied in Nigeria first.
And you practiced out there
in Nigeria first before coming over here.
Okay, so you kind of know how people work.
Exactly. Yeah.
And is it a big difference between?
There is a wide difference.
Really? What's the kind of difference?
The difference is clear. In Nigeria, the environment is structured in such a way that when you want to relate maybe a negative findings from your ultrasound scan, the response you have from the couple or from the mother or from whoever you have done the scanning is quite different from the response here. Here, people are highly emotional and anxious compared to people. I think the contributing factors could be because of the nature of the environment itself. We grew up in a more like a tough environment. You understand that? So like unlike here where everything is given to you. So those are part of the things I think are contributing factor. That does not mean we don't actually have standard sonographic practice in Nigeria, because it is my skill in Nigeria that actually I'm using here. So because I qualified as a sonographer in Nigeria before coming over here. Okay.
Wow. So what is, because I know we went to different places. But what is your journey? So how did you start out, and why did you become a sonographer?
Actually, it's an interesting one.
Good.
In Nigeria, radiography is a 5-year degree program.
5 years?
Yeah, 5 years. In UK, it is a 4 years degree program.
Okay.
So the difference is that we are allowed to have knowledge of almost all the areas of field of radiology. So radiography incorporates both the ultrasound scan, the CT scan, the MRI scan, the X-rays, and many other ones like the PET and other, oncology and all that. So
is that in Nigeria?
All of them are there. You have what I call the basic knowledge of them. So from your first year, second year, as of your third year, you are allowed to start entering the hospital to see what they are doing. So my journey was like, in my second year, I was not yet qualified to enter the hospital. So I visited my aunt there in the capital in Nigeria, and she introduced me to one hospital. I just said, let me just walk in and see what they are doing. And all of a sudden I was interested. I said, let me start, instead of starting in third year, let me start in second year. So I entered in second year. I entered the ultrasound unit, and I was so intrigued by what they are doing. It gives you, like, you do the scan. Unlike other aspects of radiography, it is only in sonography that you have to do dynamic image and report it yourself. If you are in X-ray, for instance, you have to go and qualify as a reporting radiographer, and you have limited area you can report. If you're in MRI, you are not allowed to report your images. You have doctors that are specialized in that.
Okay, so you just take the picture.
You just take the pictures and So, but in ultrasound, you have to do the scan and you have to report it.
So it's more power.
Yeah, exactly.
Okay.
It gives me that this feeling you have clinical. You understand? So when I entered the hospital, then within my second year, I had a lot of experience. Watching what they are doing. I was so interested in ultrasound. So because of it, I had to come back in my third year, and something happened in the hospital that actually made me to say, okay, this is where I'm going.
Okay, what was that?
So in the night, because of my passion, I said, let me join one of the sonographer in the night in his night shift.
Oh, to shadow him. Just
to shadow him.
Yeah.
And around that kind 12 a.m. He asked me to. By then I'm actually doing one or two things with him. I can take the probe and do little scan and all that. And he asked me to stay while he go and do something. And there was an emergency. Immediately he left, emergency came through, and that was a woman bleeding, and she was around, I think, between 28 to 29 weeks or so. And then they said, where is the sonographer? I said, I'm here. And I tried giving him a call, and he was not picking up, and that was an emergency. So they said, please, we need you to scan this patient now, because it was an emergency. So I just decided to do it.
Yeah.
I did it, and it was what we call placenta abruptio. Right. That is a condition where the placenta detached from the wall of the uterus. It's a very, very serious condition that requires immediate surgery to remove the baby.
Really? To
that cesarean section. Yeah.
Oh, really?
To bring down the baby. Yeah.
Why? What would happen if?
Because the placenta, there is a detachment. What keeps the pregnancy going is that connection between the baby and the mother through the placenta. So when it is detached, we'll have more like blood collection between the placenta and the wall of the uterus. So that is a very serious condition. So I just cited it immediately and said them, this is placenta abruptio, and they just rushed the woman to the theater. And later on, like an hour later, when the sonographer came in, he was like, Christopher, what happened?
Yeah.
I said, check the screen. Have the packs where we save the images, of what we have done. So he went through it and was like, what did I say? I told him. He said, in fact, he gave me his meal ticket that day. Then they started calling me student consultant. And I was still a student then. So because of that scenario, I had this praising, people were praising me in the hospital and all that. Yeah. So from that day, I decided that this is where I would be. It really helped me as I was leaving the university. I enrolled a year after to do my postgraduate diploma in medical ultrasound. Yeah. And I did it 1 year, I passed. Yeah. And immediately I got it, I got a job, a sonography job too, in one of the finest hospitals there in Lagos. Yeah. And not just like 3 months afterwards, I applied for a job in the UK. Yeah. And the interview was just so funny because I was like, I don't have much experience. I graduated 2016, did my postgraduate diploma 2018, and then 2019 I'm already applying to come and work here. Yeah. So the interview, they asked me some questions, and all the questions they asked me are things I know. Yeah. So I was so confident that even during the interview I just left the panel to go and be plugging my laptop. That kind of feeling like, I'm sure I'm not up to that level yet. Yeah. And I was so surprised when they, contacted me. You were successful in the interview, and they were going to handle your accommodation, we were going to bring you in and all that. So it has been a wonderful journey. So it was, I loved it. Yeah.
Wow.
Yeah, that's how actually that's what brought me here.
Yeah, that's an incredible journey.
So in 2019, I moved up to UK here, and it's a different environment, and I told myself, I have to get to understand the protocol, the guidelines, and the whole institution that regulates sonography practice here. And I registered with what we call the Society of Radiographers in the whole of UK, and also try registering with what we call the British Medical Ultrasound Society. Okay. So I'm a member of British Medical Ultrasound Society. Yeah. And then within that first 1 year in the UK, my practice was very smooth because most of the things we do here are the things I've already done
back in
Nigeria. But it's more structured.
Okay.
It has each of them have what we call protocol.
Right.
In Nigeria, the protocol exists, but there is no the structure that regulates that protocol is not there. Here we have a lot of audits and all that.
Right.
There's only a few areas where I audited back home. So these are just a few minor differences in the practice.
But the practice itself, as in the actual technique.
Yeah, the actual technique is the same. Yeah.
Okay.
The actual technique is the same, just that the difference is that why the technique is the same, why other places they regulate your technique. That means there are things you have to put up in the packs, that's the storage system.
Right.
Whereas the other side, people may not actually bother much about that as far as you give them a standard report.
Right.
Yeah.
Okay. And when you said in the first trimester, if you miss something, or is it the second trimester?
Second trimester.
So, if you miss something, you could be penalized.
Yeah.
In Nigeria, is it the same thing?
Yeah, in Nigeria, we actually have law firm, like more like the person involved can sue you.
Oh wow!
The patient can sue you, just like here. The patient can also sue you.
Really?
Yeah, patient can sue you and even sue the trust.
Whoa! What if they miss?
If you miss something that is dangerous, that actually should not be missed. You understand? So when they finally get to know about it, maybe another sonographer picked up and in a later stage, or maybe when the baby is finally out, and then they've noticed that this baby had this serious defect and you missed it, then depending on the personality of the patient, he can take it up with the trust and with you. So you will be served with the lawsuit too, together with the trust. And now that will trigger a kind of investigative process that will involve reviewing most of everything you have been doing. Yeah, it can go as that far. And when they are done with that, they can send their result or even petition the HCPC, that's the Health Care Professional Council. They would now decide on whether you are fit to practice.
Wow.
So it's actually a very serious aspect. Yeah.
But you see, when you say you're like even the second trimester.
Yeah.
Or even the first trimester, and you see these abnormalities.
Yeah.
Is there anything that you can do to change it, or why is it?
Yeah. You see, I love sonography.
Right.
Sonography have advanced, in conjunction, just like in pari passu with technology.
Yeah.
So the way the radiology technology is advancing is the way ultrasound is advancing.
Right.
So when you pick up certain abnormality at certain stage, there are many algorithms that is available on how each of the specific pathology could be managed.
Right.
For instance, a child with cleft lip, as soon as it's delivered, can be referred to the pediatric unit, where they can actually do that surgery as soon as the child is delivered.
Okay.
Now, the other aspect is if a child has a life-threatening condition at the early stage, there's a system for the partner to discuss with the specialist on whether to continue the pregnancy. You understand now? So for instance, we do the first trimester screening and someone has Down syndrome.
Right.
We'll be like, okay, it's more like helping the couple make informed choice on whether to continue with the pregnancy. You understand that?
Yeah.
So you could imagine what it would happen to a couple that, okay, this child have Down syndrome and it was missed, and all of a sudden you give birth to this child and be like, but it was missed, but probably they didn't want the child.
Right.
So we have many algorithms like that.
I see.
So obstetrics is actually one aspect of sonography. We have aspect of abdominal scans.
Yeah.
That's checking the liver, the kidneys, and all that. We have the gynae where we just check the uterus. That's a non-pregnant uterus.
Is this with the ultrasound machine?
We the same with the ultrasound machine.
Right.
We have MSK. So MSK. So so we have MSK. We have head and neck.
Head and neck.
Yeah, head and neck. Yeah, but the head is limited. We have what we call the for the fetal skull at that early stage of delivery, between the 0 to 1 year of delivery. So when we have something like a baby in the in utero, having case of hydrocephalus, they tend to bring in the baby later on for to check the ventricles and check the intracranial structures with ultrasound. So we have a specialized probe to do that. The neck involves, the neck, the muscles, the lymph nodes, the thyroid, the vessels like the carotids and all that. So ultrasound, we use ultrasound to image all the structures.
So I would have thought, this is me, again, there's probably another question, the misconceptions, but I would have thought that, like for the head and neck and all those other areas, is MRI, CT scan. These are the things that they would use more than ultrasound.
Yeah, ultrasound have limitations. Yeah, just like it's only early baby that they can use it for the head.
Right. Okay.
And for the neck,
why is that?
Like when at that early stage when the child is given birth to, there are some areas the sound can still pass through. Right. There are also another aspect of treatment. Right. I've forgotten what we call it, where we actually use the ultrasound high, because it's a very high sound wave to actually treat some intracranial tumors. But there are still researches going on that aspect. Okay. So any limit, like in terms of the neck, ultrasound does a good job. Right. Investigating any tumor within the neck.
Is that for adults and child? Or
for adults and child. Yeah. It looks at the carotid artery, starting from the jugular here, down up to the base of the neck, up to the division of the carotid into the internal and external. Oh, wow. Yeah, so we look at the carotid, we check for stenosis. So when you are in the stroke unit and they want to check, is there any clot, any more like a plaque in the carotid artery that is causing probably related to the stroke, then we tend to check for the stenosis and also the percentage stenosis and all that. Oh, wow. Yeah. So, and your thyroid gland is also scanned, also assessed for nodule, whether this nodule, and we have classification for this nodule, those that are purely benign nodule, those that have, put it in the intermediate zone. So that means that we actually need this nodule to have biopsy done on it to check if there is any malignant features on it. And we have those features that are very, very, clear that this is purely malignant lesions, and then you need also biopsy to confirm that. Wow. So scan is almost everything. And we have also advanced in scan. The recent research is going on is what we call we call it contrast enhanced ultrasound. Okay. Now in CT and MRI, we use contrast to view the body structures, liver and all that. Yeah. So there's also research going on. Ultrasound can also be used with contrast investigation to also look at all those structures. So
what's the difference then between like an ultrasound scan? Because obviously you mentioned that you did radiology, and I'm guessing
radiography.
Radiography, sorry, and all the different types of machines that's to be used. Yeah. So what is the difference between an ultrasound scan, MRI, CT scan, X-ray?
Ultrasound is different from X-ray, just like the word appears. The X-ray is just an ionizing radiation. Right. It makes use of highly ionizing radiation. That's X-ray. Right. But the one used for the X-ray you have in the hospital are actually of diagnostic range. Right. So X-ray is we now have purely diagnostic range of X-ray ionizing radiation that is used that you can use for checking the bones, the chest structures and all that. Such ionizing radiation are limited in terms of the tissue level. So we can grade from water to bone, and we have based on the physics of X-ray, we have structures that can be viewed using X-ray. For instance, if you should image the whole body now with X-ray, the X-ray might not be able to might not see the bowel properly.
Right.
But when you image it with CT, now CT is more like it's still an ionized radiation, but now it's more like a cross-sectional imaging, where it, instead of having a two-dimensional imaging like in X-ray, you now have slices of images that gives you more resolution and more detailed structures. Still, X-ray and CT make use of ionizing radiation.
And that's bad or good?
No, that's good.
Okay.
But you have it is of diagnostic range, and for CT you have the normal level or normal dose you have to take. So that will be decided based on the kind of the pathology or what the doctor wants from you from the investigation. Okay. Then MRI is magnet. So powerful magnet. That's why when you go for an MRI scan, you don't use any metals and all that. So but ultrasound is now high ultrasound wave that we now use to image. Now this has to do with transmission of sound. That's the physics of ultrasound. Now it transmits the sound, different tissues. Let's say the string, the tissue of the hand, they reflect the sound at different rate. And when it picks it up, that's what we call the piezoelectric material in the probe, the one you use on the sound. So when it picks up the sound from different tissue, based on how they reflect it, it now reconstructs it into an image. So these are the different. You can see different. The other one is ultrasound wave. The other one is X-ray ionizing radiation. While the other one is powerful magnet. So all of them are actually almost have similar, I call it mechanism, in that there is more like an attenuation. You understand, or rearrangement of just like in MRI, rearrangement of the body constituents like water and all that, H2O and all that, to actually generate an image.
So which is the I don't know, which one is the, because I always used to hear that X-rays are what's
ionizing 2D.
No, not even that. It's more bad. It's radiation. It's radiation. And CT scan is another high radiation. PET scan is another high radiation.
These are the the public actually need. We have what we call the World Radiography Day, when we try to talk to the public awareness about what this X-ray are. So the X-ray used probably for industrial purposes. Are different from the X-ray we use for diagnostic purposes. So I can have 50 chest X-ray. And I feel okay, there is no radiation effect.
Really?
So all is about the dose, and is it within the for instance, you see someone coming for, we use for CT, we can have high dose in CT, but you are not giving the dose, let's say, just like in PET scan, you're not giving the dose every day. You can have CT scan today, and probably the next time you have another CT scan might be next year, or depending on the nature of the pathology. So what we actually check is, even if there is already, we can see in our society how many people have come in to say, I'm suffering from the effect of radiation. Why? Because we are using of diagnostic range. Secondly, is that we also consider what we call the benefit of this X-ray to the condition you have. So if the benefit outweighs the risk, definitely we have to go for the benefits.
I see. Wow. So another one of the question, what is one of your general misconceptions that people have about ultrasonography or just sonography or radio?
At the moment, ultrasound, there is no any established data or research study to say this is the major effect of exposure to ultrasound wave. In X-ray, we know when you're exposed, we know that there is effect. However, people feel that having X-ray, you are going to have genetic defect and all that. Probably their next generation and all that. But actually, it's far from it. It's far because the people that set up this, the company that even produced this, there are guidelines, there are protocol there that even the sonographer is trained for 5 years, 4 years to know how to administer this dose within the level that is compatible and okay for that diagnosis and for the person. So the dose used for instance, for a child is different from the dose used for the adult.
Yeah.
So all these are in place. So we try to let people know that the X-ray we use is of diagnostic range and have no genetic effect on any of the people being used that are using it to diagnose their condition. Yeah.
So people have a different idea of what.
Yeah, exactly. Yeah. But in the UK, actually, I can see that people actually are aware because people can Google everything, you can read everything. Even before the person comes for the scan, you already have the information. So yeah, exactly.
Yeah. Wow. That's so interesting.
Yeah.
And all right. Because I know your fabulous story about the woman about the
exactly. Yeah.
First of all, did she actually thank you for that, or did you didn't see her after that?
The truth is, I didn't see her after that. That's number one. Two is in our practice, just like those in military. For instance, the British soldiers, they are there fighting. Who is going to thank them? So I believe that every profession, even a cleaner in the hospital, who is going to thank him? Everybody, the satisfaction you have by daily doing what you do, and then putting smile, on the face. I had this scan where just recently, and it was triplets.
Oh,
yeah,
wow.
Rarely do I see that. So, after doing, and the patient was so worried, and I'm going to say, but man, this is triplets. Like, what? I say, yes. The husband was happy.
Yeah.
And I saw the smile in the face. I was happy.
Yeah.
Even though it's rare, but they were all happy with it.
Wow.
Sometimes you see them coming bleeding, and you do the scan, and actually the baby is fine. The bleeding has nothing to do with the pregnancy.
Right.
What we do is, as far as you are happy with your job, and then the people, the community you are giving your service to are happy, you don't actually need that thing. That was why when they were like during the COVID era, they were like, let's clap for healthcare. I say, if you want to clap for us, increase our salary.
Exactly.
Because if you clap for the NHS, who will clap for the cleaners? Who will clap for the military that are there 24 hours in tough weather and all that? So if we want actually to appreciate what they do, get the government to increase their salary, or that's increase their pay. So that's my own view.
No, I agree. Wow. Yeah. So I was gonna ask another one. I know you have that self-appreciation that you internally, but who do you feel that appreciates you the most? Could it be like patients, government, colleagues? Who do you feel that appreciates your service the most?
Who appreciate my service more? I think I am both the I think both the patient and the I will not put the government because I'm not in contact with the government. But I put the management where I work.
Yes.
So the management where I work and the patient that come in and show appreciation, verbal appreciation intermittently, not all the patients, because you always have all that patient come in and complain. Those are the ones that sometimes the management say, oh, we're just sending you this email to appreciate the work you do and all that. It helps us, it keeps us going. And some patient when you finish attending to be like, oh, you're lovely, your service was superb and all that, keep it up and all that. So I appreciate all the even though they look little, but actually they are worth it.
No, definitely. Wow. All right. So what we're gonna do now, we're just gonna go to I call it rapid fire. Yeah. So basically what I'm going to do, I'm going to ask you 3 questions, 3 closed questions. It's either pick a choice or a yes or no.
Okay.
All right? Cool. So our first question. In your personal opinion, which organ shows more abnormalities? The pancreas or the spleen?
Ultrasonographically, I would say the spleen shows more. The reason why I say the spleen shows more is the pancreas actually ultrasound is limited in assessing the pancreas. Now, even though people will be like, oh, pancreatitis is an obvious reoccurrence, this thing that is more. But the reason why I don't go for it is because how many sonographers actually report pancreas? So also CT and MRI could be a better imaging modality for it. But ultrasound could easily pick up splenomegaly, mass in the spleen. Even though, depending on the BMI of the patient, I have been able to make some reports on the pancreas where I could see something like pancreatic pseudocyst, pancreatitis. You have to just query it and refer for a CT follow-up to actually find out what is happening. As it stands now, pancreas is still part of the protocol for imaging the abdomen on ultrasound scan. But most sonographers will agree with you that ultrasound is far limited because of its location, anatomical location. You can see that from the stomach, you have the duodenum that form like a loop around it. So the bowel gas tends to obscure the pancreas. So you can't make an authoritative conclusion or impression. All you could do is, if you pancreatic pseudocyst, you can actually infer that. But pancreatitis, a lot of things could affect imaging the pancreas. So it's always good to go for the gold standard like CT.
Really?
Yeah.
I see. Okay. Okay, fair enough. All right. For our second question. Which scan poses the most risk to our body? An MRI scan or a CT scan?
Definitely CT scan. Definitely.
For our third and final question, is there a thermal side effect ultra scanning a pregnant woman?
Fetal side effects?
Thermal.
Okay, thermal.
Yeah.
Okay. It's still hypothetical. Yeah. We have researches, a lot of research works that have come to validate that hypothetical findings, stating that there is thermal effect of ultrasound scan. However, there is sufficient data that when you use high frequency, such as Doppler ultrasound scan, there could be thermal effect. In view of this, in view of this non-pathognomic findings, meaning it is not 100%
concrete.
The Public Health England now put a policy in their guideline for obstetric scanning. We don't use high frequency Doppler scan when scanning a baby below 28 weeks. From 28 weeks is already in the third trimester, so we can use Doppler. Now we can also use Doppler below 28 weeks only if there is conditions that would be that the use of the high frequency and Doppler scan would benefit the baby more than the effect of using the high frequency ultrasound. So when you use high frequency Doppler scan, you could have, that means there is high chance, all this are more like more like hypothetical statement. We have not seen any data or any obvious effect from study that, this is actual thermal effect of ultrasound on this baby or on this pregnancy. However, we follow the data provided. So if the benefit of using it outweighs the risk below 28 weeks, then we can use, and that is only when there is a specialist request for that. So it must be a consultant, maybe an obs and gyne doctor. Then we can now use high frequency wave to do the Doppler scan. So outside that, we don't use high frequency Doppler scan before 28 weeks.
So outside of that, outside of the Doppler scan, you would say that there is no thing.
Outside of the Doppler scan, the general abdominal scan and all the scan, I can, based on the available data, there is no thermal effect. Okay, However, because all this are something people can go online to check.
Yeah.
There are a lot of research works
Yeah.
that tends to state. Let me put the word. The research actually states that there are thermal effects of ultrasound, but we don't have evidential data.
These are just the final questions for the show. So in your personal opinion, where do you feel the healthcare industry will be without ultrasonographer or radiographer?
I would think they would be in Stone Age. But just when I was during the World Radiography Day, we normally call it. You will see the logo, the Eye of Medicine.
Right. Okay.
Eye of Modern Medicine.
Right.
That's actually what we are.
Right.
So we are the Eye of Modern Medicine. Majority, let's just say more than 70% of surgical operations, follow-up studies on any disease processes must go through radiology. Name it must go through radiology. Whether you have the blood test done, go to the pathology. Whether you have anything done, you must have you want to know what is happening.
Yeah.
Even when if you feel that every other thing looks normal,
Yeah.
you tend to let's say that maybe you have checked up the kidneys and you'll be like, okay, the kidney is fine.
Yeah.
But send him for ultrasound. Let us check if the liver and all that structures look fine. You understand? So definitely ultrasound. Without ultrasound in the healthcare industry, I don't think because yes, MRI, CT. Let's just isolate ultrasound for instance and say without ultrasound only.
Yeah.
There are many limitations of CT. For instance, CT can check the gallbladder and tell you it is normal.
Yeah.
And scan can check that same gallbladder and tell you, oh, this person have gallbladder sludge.
Right.
Yeah, because ultrasound can see the frequency of ultrasound wave could detect a sludge in the gallbladder, but CT, because of its own ionizing radiation, can't see a sludge properly. You see the difference?
Okay.
So ultrasound is something that you cannot just overlook. Right. There is, because also of the advances going on in ultrasound scan, in terms of vascular scan, is less expensive, is non-ionizing, easy to use, always available for you. Can take it anywhere. You can't move the whole of CT machine to anywhere. But you can take ultrasound to the theater and do a bedside ultrasound scan and all that. Okay. So you can even take, currently with advances, you can have ultrasound scan in your phone and a cordless probe.
Really?
Yeah, that's how far we got.
So you could actually ultrasound yourself?
You can have it in your phone. And then you can scan and check, So you can see it is you can't just do without radiology. Radiography and radiology in general. Yeah.
Wow. That's incredible. Yeah, that's incredible. Yeah, so I guess you guys are really, really important in the healthcare industry. What do you think is missing from your profession? It could be, as you said earlier, pay, increased salary, recognition. I know that you have internal recognition, status, maybe beyond politics. Some people say work-life balance. What do you think is missing from your profession?
Missing in my profession at the moment. You see, I think although they're already working on that.
Right. What's that?
Sonography is more like a clinical area. Yeah. And we are meant to have, just like in pharmacy and medicine, we have what we call consultant this, consultant that. Already is already coming in place because some hospitals now have consultant sonographers. So that's number one. Number two is a structure, a regulatory structure. Sonography don't have a regulatory structure in the UK. Anywhere in the world, we don't have any regulatory structure. We only have bodies that tends to form more like a temporal, what I call temporal or intermittent regulators. For instance, you can't determine who becomes a sonographer because a doctor can be a sonographer, a nurse can be a sonographer, a physiotherapist can be a sonographer, a med lab scientist can be a sonographer. Or you need any health practitioner that can go forward in their own practice to do a postgraduate study in ultrasound can be a sonographer. So it's very hard in almost all the countries of the world to regulate sonographic practice.
Right.
But it's not that it's something that could not be done. It's just having the right policy in place. I think this is one of the major issues. It has actually made the practice, too open and not regulated.
Yeah.
Just like, look at the doctors, they are well regulated.
Yeah.
So I don't see anything wrong with, if you must practice sonography, we have a regulatory board that sees that this person is trained and is fit to do it. Yeah. I think that's the only thing I think, because when you have a regulatory body, that regulatory body will be given that responsibility to decide the programs, the level this person can attain in that cadre of the profession, the niche sonography.
That makes sense. And one of our last questions, do you see your profession progressing in any way? I know you're talking about it should be kind of regulated, but do you feel it can move into any other way? I know you're talking about like new technology where you can do it on your phone. Now I know that there's like loads of what's it called, traveling diagnostic machines. Is there anything else you would feel that your profession will be progressing?
Sonography will definitely progress in as much as imaging technology is advancing. Right. Sonography will also advance, just like the one I told you about, the series, which is is still in progress. The contrast enhanced ultrasound at the moment. When you want to check the biliary system, the bile duct, the liver, and all the intrahepatic vessels and all that, and you want to do it on CT scan. Some of them take in dye, they do contrast investigation on CT. We can also have that in ultrasound. On a lifetime image and less expensive. Okay, so that will contrast enhance ultrasound. We can administer contrast and at the same time monitor it, how the contrast move through vessels and all that. So when this field, already we have something that, because water is contrast. Anything you introduce into a space that changes the in terms of the difference between the structures, the contrast. So for instance, in what we call sonohysterectomy, ultrasound. Now in ultrasound or hysteroscopy or I've forgotten the name they give it. We introduce water into the uterus, that's the woman's womb, into the cavity, and then we tend to image the uterus to see if there is any polyp or any lesion or mass within the lining of the uterus. Okay, so the endometrium is the center lining. Is not all, except there is a collection there, you can appreciate its lumen properly. So even though it is, I don't know whether I think it's almost an outdated practice. But when you introduce water, for instance, we do it also in X-ray. When I used to practice X-ray, because I practiced X-ray before ultrasound, we introduce a dye into the uterus, and we take the X-ray, and it shows us the whole lumen of the X-ray. So if there's any fibroid, compressing it. If there is any polyp, you will always see those features. That advances actually is what gave me the idea to go into having a website where I can reach out to people.
So what's this website?
The website, when I came into it, my website should be about 1 year and 8 months now.
What's it called?
It's called UK Sono. UK Sono, people were like, some people wanted to start calling me UK Sono. I said, no, UK Sono. So UK, I named the UK Sono because it's based in UK. Most of the guidelines I'm teaching people almost follow the UK standard. However, I have people registered from both Asian countries. I have even a friend that posts some content from the USA, United States, and all that. So, and I have already made up my mind quarterly to be organizing classes and posting content in the website to bring people, let people understand actually what sonography practice is. Because if you can actually practice well in the UK, there is no way you cannot practice in the world.
So UK is one of the highest standards?
UK is one of the best, I call it one of the best in the world, where you can practice sonography. USA, in fact, you can't even compare sonographic practice in the UK to USA.
Really?
Likewise, you can't compare it with Canada because some sonographers in Canada don't even report. Yeah, only few
Really?
sonographers report their images in Canada. So, but in UK as a sonographer, you have that privilege to do your scan,
Wow.
issue your report,
Right.
participate in MDT meetings,
Yeah.
review, scan. So my website, UK Sono, if you want to log in, just www.uksono.com.
Yeah.
In 2019, I created the website. I brought in some professionals
Yeah.
that would also help in posting content, reviewing content I post, and also have a live chatting app in the website
Yeah,
where
I've seen
if you
that.
want to upload, you want us to review your images for free of charge 24 hours.
Really?
Yeah. So if you do a scan, for instance, and you're not sure of what you
Oh,
see.
that's cool. That's cool.
But that's for the meantime,
Yeah.
because we're just less than 2 years.
Yeah.
So hopefully when we have all the arsenal, to get
Yeah,
it running,
yeah.
then we can tell you, okay, for us to do this for you,
Yeah,
you have to
just
pay this.
do-
But
yeah.
now it's free of charge. If
Wow.
all you need to do for us, short clip of that pathology, images of that pathology, and then it pops us in our system. We'll review it and tell you this is our own opinion on that.
That is cool.
Yeah.
I like
Yeah.
that. That's
So it's always
good.
there. And I have coached a lot of people there. A lot of people
Yeah.
have contacted me and say, okay, what this. How do I handle it? I'll be like, okay,
Yeah.
come on my website. I'll get in touch with you, and then
That's a
we
good
sort it
idea.
out. Yeah.
And is the your website? When you're saying you're coaching and training people for UK standard, are they for people that are mostly abroad, like in Nigeria and stuff like that,
No,
or mostly for UK citizens?
Everybody. As far as I have up to more than 500 members at the moment.
Wow.
And it's increasing.
Wow.
So I also have Sono World WhatsApp group where I have up to 2,000 members.
Wow.
Yeah. Although they have depleted over time because I have been very busy with my master's program.
Oh, you're doing a master's?
Yeah.
Oh.
So I finished my PhD in Nigeria, and I came in here last year. I decided to run for my master's in medical ultrasound still.
Wow.
So I've already completed the program.
Congratulations.
Just waiting for the final dissertation results, which I know I'm going to
Of
pass.
course. Okay.
So hopefully by end of July, I should have my master's in medical ultrasound.
Wow.
And the essence of going to master's is not to affect my practice in NHS. It's actually to help me gain more research information knowledge,
Yeah.
so that when I'm coaching you, I also have the necessary background training to do what I'm doing. Hopefully also in the next couple of years I should also be pursuing my PhD.
Wow.
The same niche in medical ultrasound still.
Wow.
Yeah. So it's good to actually be good in your niche.
Yeah.
So my niche now is medical ultrasound.
Yeah.
So some other person can have their niche in MRI and CT, but my niche is medical ultrasound, and I want to give the best I could in medical ultrasound.
You're that's fantastic, man.
Yeah,
You
thank
doing
you.
very
Yeah.
well. Wow, that's
Yeah.
amazing.
Yeah.
Yeah. I'm blown away by how much you know. You know what I mean?
No,
so much. That's
I don't know
incredible.
much. I in NHS currently I'm part of the fetal medicine clinic team.
Right.
So we are the one that is a special team separate from. We just have few sonographers that are there.
Yeah.
So we do what we call the fetal anomaly scans.
Yeah.
With consultant in the room.
Okay.
So when, for instance, a sonographer has scanned this patient,
Yeah.
and say, "Oh, I'm seeing something that looks like a cleft lip,"
Yeah.
he sends it to the fetal medicine clinic. When I have a day, I will now come in. The consultant will now come in. While I do the scan, we now put our heads together and say, "Okay, yes, this is this."
Wow.
Yeah.
So you're out.
Yeah. So the Lord, will I say, some people don't believe that it's actually God helping them, but I believe God has helped me to reach that level.
Exactly.
Because I'm just 2 years in the UK, and I'm part of the fetal medicine clinic.
Wow.
I have a lot of fetal medicine certificates.
Wow.
I do a lot of fetal medicine screening scan, and even lumps and bumps, I'm already into it. Head and neck.
Really?
Yeah, lumps and bumps, I do it, yeah. And I'm also planning next year to finish up my PGC in MSK. So hopefully by end of next year,
I'll be referred.
I'll be into MSK already.
That's cool.
Very soon I'll start my MSK training. Yeah.
So I know you're in so one thing about I know because would you always advise pregnant women to get an ultrasound?
Pregnant women, we have just like that's why I love here. In my country, you can decide to have ultrasound anytime.
Yeah.
there is, just like I said, there is no known risk of you having multiple pregnancy scans.
Right.
However, it's not always advisable to
right.
always go for scan for
Right.
no particular reason.
Right.
Something must guide you. Either you are not feeling the baby's movement and all that, and that should guide you for ultrasound scan. You don't just do things for doing things. You must have a reason.
Right. So if you feel okay with yourself, you're okay.
And as much as you are feeling the movement of the baby perfectly, you are not bleeding, no severe pain or any localized pain that is giving you of any concern.
Yeah.
You are good. Okay, but when your midwife will always discuss all this with you and tell you, if you feel reduced, for instance, you are feeling the movement properly today, tomorrow you are not feeling it much as before, you can say, oh, there is reduced movement and this is giving me concern, then you can seek for ultrasound scan. Yeah.
That makes sense.
Yeah.
That makes complete sense.
Yeah.
Oh man, you've been terrific. You've been great. You've been great.
Thank you.
It's been such a pleasure to have you here, man. So for our last and final question, this is a show called The Professionals You Should Know.
Yeah.
Is there any other professionals that you think we should know?
Okay. Just like I said, I've not interfaced with a lot of people. However, aside Nemekugu, who is also in the kind of field I am, Sydney Uregu, I just probably got the name right.
Yeah.
Is I think he's specialized in biomedical engineering.
Ooh,
I think, and he's actually good in what he does.
Yeah, that sounds good.
I think you can check him out.
Yeah, biomedical engineering. All right, I'm gonna check you out. But as I said, it's been absolutely amazing having you here. Thank you for coming on, and
thank you very much.
We've gained so much knowledge, and it's really appreciated.
No problem.
So thank you.
Thank you very much.
Thank you all for joining.